Hello, everyone. My name is Dr. Eugene Wright, and I hold an appointment as Consulting Associate in the Department of Medicine of Duke University Medical Center and currently serve as the Medical Director for Performance Improvement at the South Piedmont Area Health Education Center, or AHEC, here in Charlotte, North Carolina. I'd like to welcome you to this independent medical education program on CGM device updates, which will share with you a couple of exciting innovations, advancements, and discoveries in continuous glucose monitoring that were presented at the ADA, or American Diabetes Association, 84th Scientific Sessions held in Orlando, Florida, between June 21st and June 24th, 2024. While there were many intriguing sessions at the ADA this year, I will focus on just a few key sessions in particular which I feel will impact your practice the most. In the opening address titled, Dissociations Between Technology Advances and Health Outcomes for Diabetes in the U.S., What Should We Do Differently?, FDA Commissioner Dr. Robert Califf argued that technology advances aren't fulfilling their promise for improving diabetes or overall health outcomes in the U.S. Dr. Califf pointed out that technology as not always reaching those who might benefit the most. Technology has brought incredible advances in diabetes, notably continuous glucose monitoring and pumps that make life more manageable for patients. However, Dr. Califf pointed out to a truism that Ed Young wrote in The Atlantic, technological solutions tend to rise to society's penthouses while epidemics seep into its cracks. In a day one panel discussion regarding new technology, equity, and access, included thought leaders from across several disciplines discussing the implications for technology, equity, and access. Dr. Ramsey Ajan of the University of Leeds in the UK noted that Black individuals with diabetes have greater hospitalizations for hypoglycemia, perhaps due to overtreatment of elevated measured A1C values compared with the average glucose related to their red blood cell biology. In their study, they used CGM and bi-monthly A1C collected in a 26-week study of adults with type 1 or type 2 diabetes across different racial groups. They noted a significantly different A1C and average glucose-derived A1C discordance, particularly in Black individuals with A1C levels being measured higher than average glucose-derived A1C. This suggests that CGM metrics may be better than A1C for assessing glycemia in Black patients. In another presentation from this session, Dr. Mehta Munshi, director of the Joslin Geriatric Diabetes Program, discussed the implications for CGM use in long-term care facilities. In her study of 65 residents with a mean age of 65, 50% were female. 14% of the cohort was on a sulfonylurea medication, and 68% were on insulin. The CGM data showed that 26% of the cohort, with greater than 1% of the time spent in hypoglycemia, or below 70 milligrams per deciliter. A larger burden of hyperglycemia was seen in 54% of the cohort, spending greater than 10% of the time above 250 milligrams per deciliter. 37% of the cohort were spending greater than 25% of the time greater than 250 milligrams per deciliter, and 14% of the cohort were spending greater than 90% of the time above 250 milligrams per deciliter. Fingerstick reading frequency was 2 times or fewer per day in 74% of the cohort, 3 times per day in 13% of the cohort, and 4% or more times per day in only 13% of the cohort. On average, this cohort had 13 comorbidities, with 85% having functional disabilities. Now, the A1Cs in this cohort showed that 45% had A1Cs of less than 7, 27% had A1Cs between 7 and 8%, 12% had A1Cs between 8.1% and 9%, and 16% had A1Cs greater than 9%. Her conclusions from this study was that patients with diabetes living in long-term care facilities have a high burden of both hypo and hyperglycemia, despite what otherwise might be considered fair control of their A1C. More consistent use of CGM would help identify glycemic excursions to improve therapeutic decision-making. On day 2, Dr. Eden Miller of Bend, Oregon, in her presentation showed data and evidence that CGM helps not only patients on insulin therapy, but also patients on non-insulin therapy. This was presented previously as a poster. More recently, incremental A1C benefit of adding CGM to patients on a GLP-1 receptor agonist was demonstrated in a real-world observational study of a large U.S. claims database. That study showed that adding CGM to GLP-1 receptor agonists provided additional A1C reduction. After a Freestyle Libre acquisition, the average A1C decreased from 9.8% at baseline to 8.3% in patients on GLP-1 receptor agonists, with the last prescription being within 90 days prior to the acquisition of the Freestyle Libre. In another study, starting CGM within 30 days of a GLP-1 receptor agonist compared to those patients who were just on GLP-1 receptor agonist alone without CGM, the cohort had a greater A1C reduction at the first A1C that was 60 to 300 days post-CGM acquisition, with a drop of about 2.3% with CGM versus 1.73% with the GLP-1 receptor agonist alone. These studies provide evidence for the benefit of adding CGM in patients with GLP-1 therapy. Throughout the meeting, several posters and presentations demonstrated the value of CGM for primary care practitioners. One poster by Dr. Satish Garg used the Optum's de-identified market clarity database of over 79 million people to evaluate CGM use in approximately 74,000 people with type 2 diabetes who were treated with non-insulin therapy, basal insulin therapy, or prandial insulin therapy. The primary outcomes were changes in all-cause hospitalizations, acute diabetes-related hospitalizations, and acute diabetes-related emergency room visits during a 6 and 12-month period post the index period. The index period corresponded to the acquisition of the CGM. The results were striking. In all categories, the non-insulin therapy, the basal insulin therapy, and the prandial insulin therapy showed significant improvements in all-cause hospitalization, all-cause diabetes-related hospitalizations, and all-cause diabetes-related emergency room visits. Furthermore, these reductions were sustained during a 6 to 12-month period for all groups again, and all were statistically significant. The conclusions were that the use of CGM in the real world across different therapeutic regimens in people with type 2 diabetes was associated with significant reductions in all-cause hospitalizations, acute diabetes-related hospitalizations, and emergency room visits. Ms. Valerie Ruella of USC presented 6-month outcomes from the Hankey Project, which provides free CGM and remote monitoring for 1 year to people with diabetes from under-resourced backgrounds in Los Angeles. Participants were provided an Abbott Freestyle Libre 2 CGM and followed via LibreView. Additionally, data from blinded CGMs were obtained at baseline, 6 months, and 1 year. The ambulatory glucose profile, or AGP, and clinical data were sent to the principal investigators as clinically indicated, either weekly, monthly, or quarterly, which allowed the healthcare professionals to make CGM-based recommendations based on the LA County algorithms for diabetes management. The project staff reviewed the LibreView daily, and participants were contacted with diabetes education if their glucose values were less than 70 milligrams per deciliter or greater than or equal to 250 milligrams per deciliter more than 5% of the time. There were 195 participants who have completed the first 6 months. Non-insulin users saw a 3.6 hour per day improvement in their time in range from a baseline of 53% to 68% at 6 months. Insulin users also saw improvements from 47% at baseline to 59% at 6 months, resulting in a positive 2.9, almost 3 hour per day increase in the time in range. Non-insulin users saw a 2.2% reduction in the A1C from 9.7 to 7.5% at 6 months, and insulin users saw a 1.3 reduction in the A1C from 9.3% to 8% at 6 months. Ms. Ruella explained that these improvements were sustained at 12 months, but importantly, all their 12-month data isn't in, but they will be continuing to follow that through February of 2025. What she did note, importantly, that diabetes distress was significantly decreased in both groups. Due to CGM remote monitoring, there was significant uptake of GLP-1 receptor agonists in the cohort. In the non-insulin users, about 72 patients, GLP-1 use increased from 14% at baseline to 39% at 6 months. In the insulin cohort of 123 patients, saw an even greater increase from 24% at baseline to 69% at 6 months. Ms. Ruella noted, while there was significant increase in incretin uptake, only 2 participants in the non-insulin group began insulin post-baseline. Dr. Ann Peters, who was the PI, noted that CGM uptake has been incredible in this population. While remote monitoring requires significant time commitment, the researchers hope that remote monitoring systems will improve in the future to expand this work. Dr. Tom Grace presented his data showing that a collaboration between a primary care practice and a local public health department to improve CGM access could favorably impact diabetes outcomes. In his study, CGM systems provided by Dexcom, the G6 or G7, were provided to eligible participants with type 2 diabetes who were greater than or equal to 18 years of age, CGM naive, and did not have health insurance coverage for CGM. The outcomes included changes in A1C and CGM metrics from baseline to 1 year. His results showed that of the 177 participants, the mean age of 59, 41% were female, and the mean BMI was about 35.5, with a mean duration of diabetes of 9 years. After 1 year, the A1C decreased from 9.4% to 7.1%, a 2.3% drop in the A1C. The proportion of patients meeting the A1C target of less than 7% increased from only 1 patient, or 0.6% at baseline, to 91 patients, or 51.4% at 1 year. Those patients meeting the HEDIS target of less than 8% increased from 19.2% at baseline to 85.9%, nearly 86% at 1 year. CGM outcomes for 109 patients after near continuous use included total increase in time in range of about 9.9 or 10%. And there was a large increase in the time in tight range, or time in 70 to 140 milligrams per deciliter. His conclusion was that self-guided use of CGM by primary care patients with type 2 diabetes for 1 year was associated with clinically meaningful improvements in A1C and time in range. What I found striking about this study is that the patients received limited education on diabetes or CGM. On Monday, in oral presentations on new technology, continuous glucose monitoring, Dr. Sean Osher of the University of Colorado described his Prepare for CGM study that describes strategies for implementation of CGM in primary care practices. He spoke about different resources and tools to assist with implementation, to include the AAFP CGM implementation models through the AAFP TIPS program and the virtual CGM implementation services, VIR CIS platforms. He noted that diabetes care and education specialists have potential to become the diabetes technology champions for the busy primary care practitioner and should be integrated into the multidisciplinary team in primary care. His toolkits and platforms are suited for primary care practitioners that are eager to implement technology but uncertain how to go about getting started. I think the key takeaway points are that continuous glucose monitoring is an incredibly powerful tool in clinical practice to help our patients better understand and manage their diabetes. It can help guide nutrition choices, enable timely and effective medication management on the part of the HCP and the patient, and it can help prevent harms associated with hypoglycemia. Implementing CGM in primary care practices is feasible, and improved glycemic outcomes as well as reduced diabetes distress. However, it is best done with a team-based approach. There are a number of available resources to help clinicians and practices get started using CGM in their practice. I hope you will check out Springer Healthcare IME's CME-accredited interactive infographics and tutorials where I, along with Dr. Rosalina McCoy and Dr. Jennifer Green, dive deeper into the most important considerations for CGM use in primary care. Thanks for listening to this podcast update. Stay tuned for the next podcast where we will continue talking about recent updates in CGM field.